And the team has been incredibly accommodating of me and very helpful in getting the live stream set up. So if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So this is an interesting case. I always like doing these because we seem to really help these patients by doing the surgery that we are recommending. So this is a 4-year-old cat that has a history of, and I'm sorry if my head's in the way, I'll try to keep it out of the way. 4-year-old cat that has a history of recurrent obstipation, and it's been going on for at least a year and a half with 3 episodes of megacolon within the past month. So we've discussed medical options versus surgical treatment, and the owners wisely have opted for surgical management. And so what surgical management involves is a subtotal colectomy. And the reason why it's called a subtotal colectomy is because we can't remove all of the terminal colon that's in the pelvic canal. Key things here are to make sure that we do a good anastomosis and that we don't have leakage, because leakage is catastrophic in these patients. The other thing is that we want to make sure that we remove enough of the colon that we're not going to have recurrence with or recurrence of the obstipation. So just let us know where you're watching from, and you can ask questions as I go, as always, but if I'm in a critical part of the surgery, then I might not answer for a little while. Can we get some sharp, large Gelpia retractors? So I've got a lump here, which is the urinary bladder, which we will empty with a needle during the procedure. So this is a surgery that can be done in general practice, but you just have to be really comfortable doing intestinal surgery and make sure that you're confident in doing a really good anastomosis that's not going to leak. And I'll give you some hints as I go about making sure that you get a good anastomosis. That being said, leakage probably still occurs in 2 or 3% of these patients, and when leakage occurs, it is catastrophic, so it can be fatal. So I want to make sure that my laparotomy goes all the way down to the pubis, because we are going to have to make our anastomosis as distal as we possibly can to try to avoid recurrence of the megacolon. So I'm just getting my sharp Gelpia retractors here. You can use a Balfour, but I just find in cats that Gelpia retractors work really well. And I do apologize if my head gets in the way. If you guys see that my head is in the way, just let me know and I'll try to move. Okay, so we'll go ahead and empty this urinary bladder. I'll just take the needle, I think, and then we'll get the suction. And I'll go to an avascular part of the bladder. You ready to go? Oh, we can actually stick that on there right now. And then we'll just pop that in. So I'm just doing a little cystocentesis using a needle and suction to try to get this big urinary bladder out of the way. To make sure that I'm not grabbing onto anything important with my Gelpies. I've been so impressed since I arrived here on how good the quality of all the equipment is and stuff. It's really a pleasure to use nice new equipment. Can I please get some 4.0 PDS?
4.0 PDS wrong?
Yes, please. I'm just going to do a little cruciate over my cystocentesis because it is leaking a little bit of urine around it.
Okay.
And can I get a larger needle driver, please?
Yeah.
Thank you.
Do you want us to empty using a syringe?
Do you want to try with the syringe instead? Is that what you're asking? Yeah, that's
Yeah.
fine.
Maybe you try the syringe. Can I please cut the suture, please? Thank you.
And just, yeah,
Sorry.
about 4 mil. Yep, perfect. That's great, thank you. Can we get the ligature handpiece open, please? Thank you. Hi, Brazil, Canada, another one from Brazil. I think we had Mexico and India. And I've never streamed from outside of Australia, so this is kind of exciting.
Could we have another syringe, please? 10.
10.
Yep. Somebody commented 75 watching and only 5 likes. That is a tough crowd. Egypt, Morocco, Los Angeles. That should be enough.
Okay.
Yeah. All right, so we'll have a look at the colon here, and it doesn't look horribly dilated at this point, but if you would have seen it on radiographs, it was really huge. So just getting a look at our anatomy here, we have our cranial mesenteric artery here that's releasing branches to the right colic, the middle colic, and then we have the caudal mesenteric here with branches to the left colic, and then we've got the cranial rectal branch sitting right here. So it's critical that we preserve as much of the cranial rectal artery as we can to preserve the blood supply to the colon. So I like to do ileocolic anastomosis. I think that if you do a colocolic, number one, it's really hard to mobilize this cranial segment, and number two, you can leave too much of the colon behind. Do we have a moistened lap sponge, please? Thank you. We'll just lay that down over here. All right, so what I'm going to do is I'm just going to start using my ligature to isolate vessels. And ligature is the biggest cheat in veterinary surgery. It just makes things so much quicker. Unfortunately, it costs about $40,000. You can get them secondhand for a lot less, but that just makes life so much easier and quicker. So this is the branch of the cranial mesenteric artery here that I've just ligated. And now this is the caudal the cranial rectal, the caudal mesenteric, and that's the cranial rectal there. I'm going to try to preserve, let's see what we've got here. I'm going to try to preserve that caudal mesenteric. So see, at this point I'm going right along the mesenteric surface of the colon to try to preserve that caudal mesenteric to cranial rectal artery. Okay, so I'll see, sometimes you can peel off that. See, if we just, let's see what we've got here. So that's the cranial rectal there. So I think what we're going to have to do is probably come to about that point there. So I don't want to make my life too difficult as far as trying to do an anastomosis in a deep hole. So I am in Singapore because I'm doing a locum here helping out while the owner of the practice is away. Just to protract on the colon, please, for me. So that's cranial rectal there. I think I'm going to have to, if I try to do my anastomosis right here, I'm going to leave too much of the colon behind. And so there's potential for recurrence, so I am going to have to ligate that vessel there. Okay, and then I'm just going to mobilize the caudal segment. And then what I'll do is I'll get my 4O PDS. Let's see what we've got here. Have I isolated enough? Yeah, so that's my ileocolic vessel there. And then I'm going to have a little branch right in here as well. Can I get a hemostat, please? So there'll be a little mesenteric vessel that's running along the surface here where if you don't ligate it, it's not catastrophic, but you are going to have annoying bleeding. So hold on to that. Okay, and then let's try to exteriorize that terminal segment there and figure out where we're going to do our anastomosis. I think to probably about there. Let's try to twist that around other way. Yeah. So my cranial rectal is right there. So I'm probably going to do a ligature right in here. At this point, the colon should start turning black or purple. Okay. Now what I'm going to do is get my Carmalt, and so we're going to try to milk some of the contents up to here. So I've got a Carmalt, which is a traumatic forcip, so that cannot go on colon, that's going to stay in the cat, and then we'll get a Doyen. Now whenever you use a Doyen or anything you're going to put on the intestine, you should be able to clamp it on your own hand like that without it causing a lot of pain. Okay, so I don't know if you guys can see that, but so see how I can do that without crying?
Yeah.
Yeah, so anything you're going to put on the intestine, you have to be able to put on your hand without crying. All right, so hold on to that, please, and I'm going to try to milk some of the contents out of that terminal colon. And then what I'm doing is I'm going a little bit farther down the path so that I can have a little bit of mobility in that segment to make it a little bit easier. Now, we're going to have to pack this off. Get another moistened lap sponge, please. Is that moistened?
Yep.
Yeah. So we'll pack that underneath here, and let's get some suction going. Okay, and I have to make sure that... All right, so I'm going as close as I can to my ligature on the cranial rectal vessel. Okay, so there's not a lot of fecal material in there, which is good. Do we have something that I can use to grab onto my camera? I'll just take this out. And what I'm trying to zoom in a little bit so you'll be able to see. So when I click the doyens, I'm doing a single click, so no more than that. All right, so now we go to the other end, and I'm going to put another doyen. Now the problem with doing an ileocolic anastomosis is that I have a lot of disparity in the luminal size, right? And so I have to figure out how I'm going to deal with that. The way that I like to do it is to do kind of a modified cobra appearance. Okay, now what I'm going to do here, let's suction that. Okay, so the other thing I need to make sure is that I'm not twisting the bowel or including any other loops of bowel when I do my anastomosis. So that's all out of the way there. So I'll twist that around like that. All right, and then we'll pack that all off again. Okay. And I still haven't totally dealt with my luminal disparity. All right, so what I need to do here go ahead and section in there. And then I'm going to take the ends, these corners off. Okay. So now, and there's a question about whether I give the patient an enema before surgery. I do not, ideally, unless it's already had one to manage the obstipation, because we're trying to avoid having too much liquid feces. All right, so we've got mucosa and submucosa, and then we've got serosa and muscularis here, so I have to include all layers. So what I'm going to do here is just do a little stay suture at one end. Can I get another 4-0, please?
Yep.
Yes, please. And what I'll do is I'll just clamp that with a hemostat. Thank you. And then we'll leave that long. And then another 4-0. Thank you, Monica. All right, so then I'm going to come at the other end and put in another stay suture. Making sure that I go through all 4 layers. And then I'll just tilt that away a little bit. So that's just mucosa and submucosa, and then that's my muscularis and serosa here. And hemostat on that guy there. That's, yep. All right. Now what we'll do is we will stretch this out like this, and by stretching it out, it's going to force me to put my sutures closer together, and it also is easier to handle the tissue by keeping it stretched out. There's a question about anti-mesenteric to mesenteric anastomosis. It doesn't really matter. It's just the way that it fit best. And so I'm going about every 2 to 3 millimeters apart with my sutures. And the key when you're doing intestinal surgery is to maintain tension on your continuous suture line as we're suturing. And then making sure that I'm getting all 4 layers. And then I'm using my thumb forceps to direct my suture loop. And then you can keep quite a bit of tension on that. All 4 layers here. And quite close together with our sutures. And keeping quite significant tension. Let me just bring that around a little bit so I can see what I'm suturing here. And the main reason for leakage with these is not maintaining tension on that running suture as you're going. I can already tell that I've got a gap there. Okay, and so I'm going to have to go back and put in a simple interrupted suture later. A bit more tension. And a bit more tension. And I always wear loops when I'm doing this surgery because I feel like I can more accurately place my suture bites. Probably doesn't help that I'm almost 60 and a bit farsighted. And you guys that watch my videos a lot would know that I don't tend to leak test. What I do is I just probe with the smallest hemostat or smallest instrument we've got in the pack. And I'll do that after I've done the whole procedure. A little bit more tension there. I can get one more. And even if I pass my stay suture, it's not a bad thing to overlap a little bit. And that corner is where you're going to have leakage. So I've gone past that corner there now. And just pull that. Yeah. And it's really important that you pull on both ends of your loop to make sure that you tighten. Okay, you can cut both of those off. All right, so let's go back and have a look at what we've done here. All right, so that looks great. I am going to go ahead and put one more little bite while I'm thinking about it, one more little suture. What's this guy? While I'm thinking about it, because I do have, let's see, a tiny little mosquito. So right there, see how I can not totally get in there, but pretty close. So. So just a little simple interrupted. And the reason why I like simple continuous suture patterns is because I can put a lot more sutures. If I was doing simple interrupted, this would take me a week to do all those sutures that I'm doing. Yep. All right, so now we need to do the flip. All right, so now we'll pass that Can we get another hemostat? Okay, and then we need to pass this suture. I think as a good surgeon, I'm not meant to be touching my back table, and I should be letting Monica do her job, but I'm being annoying and reaching back there. You can just hit me with an instrument if I reach over there. Just give me a knock on the. You can give me a knock on the fingers if I'm annoying you by taking instruments off the back table and not letting you hand me to them. Okay, so what I might do, I might go ahead and release this. A little bit of fecal material here. All right. And we can release that to just give me a little bit more mobility. The little needle goggles, that's great, thank you. And the bakies. Alright, so just have to make sure that I come right up to my stay suture to put my first throw, or my first bite. Okay. And the holding layer of the colon is the submucosa, just like it is everywhere else in the small intestine. But in order to get the submucosa, you have to get the mucosa. Now with all this mucosa protruding here, we could trim that a little bit. Just to make it a little bit easier to make sure I'm getting all my layers. And key is to just make sure I go all the way back there and get all 4 layers. Okay, and then maintaining tension on that stay suture. If you guys haven't visited Singapore, it's really a great place. Very friendly people and excellent food. And the street hawkers that sell food, and it's really, really cheap and really delicious. And I think in some countries, the street vendors, might be issue with hygiene and stuff like that, but in Singapore, the hygiene standards are apparently so high that it's not a problem. And I've had a few meals from the street vendors, and so far so good. I haven't had chili crab yet, which I'm very excited about. The other thing that I'm going to do in this case is Mentalize. Pretty much anytime I go in the lumen of an intestine, I'm always going to patch omentum. It's quite funny. So my connection with this practice is that I used to work with the internal medicine specialist from here, Dr. Anne Claire Duchossois, and it's funny that in Australia she was my employee, and now I'm her employee, since she's an owner of the practice. But she's a French vet, ACVIM internal medicine specialist, and is a very, very funny lady and very good internal medicine specialist. By way of efficiency, you see how I'm re-grabbing my needle after every bite with my needle drivers so that they're ready to go on the next bite, so it makes me much quicker with my suturing. I try not to grab my needle with my fingers. Not that it's a major problem with, causing a break in sterility or puncturing my glove, but it's just not very efficient. So I'm trying to eliminate unnecessary steps. So this is the mesenteric border of the ilium here, and it's really important that you're very accurate with your needle placement so that you actually are crossing over and getting that mucosa or getting that mucosa and submucosa, muscularis and serosa. Because if you're going to have leakage, that's where it's going to be. So rounding the bend here. Let me just grab this here. Hold on just a second. My loop didn't get placed where I wanted it. I've got a little bit of bleeding. I think I punctured my vessel. Where's my ligature? Alright, so now we'll go back with our tiniest hemostat that we can find. Put some tension on our stay suture. And probing's been found to be more predictive of leakage than leak testing. It's a little bit far apart there. I will put in one more suture. I couldn't get the probe through, but just to be sure, or extra safe. All right, and I'll do the pass again, just so I can look at the other side. No, that looks really good. All right, so now we can cut our stay sutures, and we'll leave the suture in, but we'll just cut the tag at about 4 mil. So there's a question about how safe it's, or when is it safe to feed these guys? I feed them as soon as they're awake. So as soon as they're willing to eat, I'm ready to start feeding them. There's no, unless you have a dog that's, or a cat that's vomiting before surgery, there's no reason to withhold food. All right, so we can see that anastomosis, I think, looks great. Let me just have a look at this. There's one little spot here that's a little bit broad. Yeah, I will go ahead and put in another suture there. And I'm being a bit overly cautious, but spending an extra 30 seconds right now might save us a revision surgery with peritonitis and okay. All right, so now let's find our momentum. Let's see if we've got a pedicle that'll reach all the way down here.
So can I ask a question?
Yeah?
Is this the level of bruising that we are seeing normal when?
Yes.
Okay.
Yeah. So Chessie is just asking if the amount of bruising that we're seeing is expected, and that's absolutely expected here.
Okay.
All right. So I'll get some suture, please. Just whatever we've got there is fine. I'm just going to tack down my. Momentum. I'll leave that. Oh, you can go ahead and cut that off. And these tacking sutures, these bites, they don't have to go into the lumen. It doesn't matter if they do, but just a nice little superficial tack I think is fine. Just make sure I don't pick off my cranial rectal artery, which I think is on this side over here. That's a little bit friable. Yep. And then the other thing I need to do is, if there are any residual holes in the mesentery, I need to just tack that up as well.
I think your head is working.
Thank you. I never said I had a small head. I am a surgeon after all. Yep. Careful not to get my caudal mesenteric as well. Can we get some warm saline, please? And some 2O PDS. Yeah, and warm saline. Is that?
It's a bit cold.
Bit cool, okay.
There's a question about the mentalization.
So there's a question about, is it necessary to suture the omentum? Look, the theory is that it'll find its way there anyway. I figure for an extra 5 minutes, I just like to suture it in place because I want to give it a head start. There's certainly no evidence one way or the other as to whether you need to suture it or not. Can I get some towel clamps, please? What's the temperature?
40.9.
40.
0.9.
Great. I want to show that on the camera, but can you just bring that over here? Actually, I'll do it in just a second. That's what I'll do. When I scrub out, I will. So they've got a device here that you buy at a hardware store, which is thermography, like a temperature sensor that I've never seen used to check to see if your fluids are appropriate temperature. I think they cost about $50 or $100 or something. And they're actually pointing it at the fluids to make sure that it's an appropriate temperature, which is just super clever. And I'll definitely be taking that idea home with me. When I'm finished suturing the abdomen, I will zoom the camera out and I'll show you that device. But it's a little gun that, again, you buy at a regular hardware store that's just going to measure temperature using infrared. Have we lavaged already?
No, not yet. We are not
Okay. We didn't have any contamination, but we will go ahead and lavage anyway. Oi. There's a question about, have I seen many cases of ischemic necrosis following anastomosis? I'm not aware of any cases that I've seen. It certainly is a potential risk, especially if you damage that cranial rectal artery, that you could have ischemia of the anastomotic site. But I have not seen it. Oh, yes, I have. I have seen it where I did a mesenteric lymph node removal, thinking that it was a huge mesenteric lymph node, and I devitalized the whole jejunum once in the dog. It was still viable at the time of surgery, but about 3 days later, it represented with septic peritonitis, and they explored it and found that it had a necrotic. The entire jejunum was necrotic. And I've always said that you cannot remove the mesenteric lymph node in dogs or cats, but I had this one case where it had a big mass, and I was dissecting and checking as I went and checking pulse oximetry and everything on the intestine, and it seemed to be viable, but again, we got that ischemic necrosis of the bowel a few days after surgery. Okay. Probably remove those towel clamps. Just grab something to try to zoom out on that camera. Let's use that one. Next surgery, I'll get Chessie to wear a microphone as well, so you can ask me questions. Got a little knot in my suture. So let's see if I can rescue this. I may be out of luck here. As a former practice owner, I hate wasting suture. No. I think I've got enough. Yeah, so just hold on to that and I'll cut out my knot. So just grab a hemostat on that. And I'll start at the other end. Chesty. Just
Sorry.
starting, that's right. Just starting at this end.
I think we are about done. Give us a few minutes. Then we are about done. Give us a few minutes. Then before we go and get ready. Probably take 3 minutes. Also, then this week, so Charles is 30, okay, for subcutaneous.
Yes, it is.
And then skin stapler or nylon?
Probably nylon.
30 EDS cutting, and then after that 30 nylon.
Yeah. Let me just make sure that yeah, that's fine. All right, so I'll leave this to Chessie to finish, and I will just, so there's a question about if I need a license. In Singapore, yes, I did have to get a vet license and had to go through a whole process of getting licensed here, providing photographs of all my diplomas and degrees and showing a letter of good standing from my veterinary board in Australia. But it wasn't too bad. It was as innocuous as it could be. So post-op pain control, this cat will get meloxicam in hospital. It'll get a CRI, I think. Is that what it's? Yes, a fentanyl CRI in hospital, and then to go home it'll be meloxicam, and maybe it'll be on gabapentin, and then sometimes we put a fentanyl patch on. We haven't discussed that yet. Any question about internal herniation? So you could have a hernia going through the mesentery, but I did my best to close that mesentery, so that shouldn't be an issue. When you suture abdominal muscles, do you focus on full thickness of the muscles or just, and the peritoneum, or just the fascia? So when you close the abdomen, all you need to get is the rectus abdominis fascia. You don't need to get the peritoneum or the muscle if you're off midline. Already answered that question. You can use a Gambi pattern, but I find that with the Gambi that's going to compromise the lumen. So I think that the easiest is just a simple continuous suture pattern. So post-operatively, we're going to feed the patient immediately, just manage pain, and monitor for peritonitis, although I really don't anticipate that being an issue because I'm really happy with the anastomosis that we've done. Hi Colombia, hi Russia. After surgery, so the big, that's something I didn't discuss, so the potential complications with this surgery, the big one that we see is chronic diarrhea, and that's related to the fact that we've eliminated the colon, which is the primary organ which resorbs water out of the feces, and that's kind of how the whole procedure works. And so you can have chronic diarrhea, although that tends to recover. Other potential complications would be a stricture at the anastomotic site. I've never seen that happen before. You could have recurrence of megacolon just in that terminal bit of colon that we have left, sometimes requiring a second surgery. I have had that happen once or twice. And then the most catastrophic one would be leakage from the anastomosis. So the reason for the subtotal colectomy was megacolon. So just a single click on the doyens. So a cutoff regarding when you go from medical management to surgical management, pretty much I'm a believer in a 3 strikes and you're out, which means if you have a cat that has 3 times obstipation over basically any period of time, it's time to start considering surgery, and the success with the surgery is about 90%. Hi Toronto, hi Indonesia. So vascular surgery is not very common. I can't think of many situations where you do a vascular anastomosis except for maybe renal transplants, and that's not being done that commonly anymore. It was done fairly commonly kind of in the 90s and 2000s in cats with chronic renal failure. They were doing kidney transplants, but that I think probably has kind of fallen out of favor because the survival following renal transplants was no different from medical management of chronic renal failure. The other place where they do vascular surgery or cardiovascular surgery would be mitral valve repairs. They do a lot of them in Japan, and they're setting up sites probably in the US and also in the UK. Hi Texas, Vietnam, Chile, Ottawa, Chile, San Diego, Houston, Colombia, Iran, Egypt, Morocco, Los Angeles, Buenos Aires, Brazil, Kansas, Brazil, Canada, Brazil, Trinidad, Tobago, Morocco, India, Mexico, China, but I'm Persian, Flagstaff, Arizona, Philippines, Argentina, Venezuela, LSU, San Diego. So I'm going to wrap it up now. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. I am doing an enucleation in a cat today, and I will see if I can live stream that one as well. Thanks a lot for watching. We'll see you again soon. Okay, thanks guys.
Cool, thank you.
A bit of